strong data about which is best. Obviously, Hepzato is the only FDA-approved liver-directed therapy specifically for uveal melanoma, so we do have really strong data for that. But in terms of ablations, histotripsy is approved for any liver metastasis. Is that correct, Jason? So not necessarily uveal, but uveal goes to the liver, so it is approved in that regard. But immunoembolization, radioembolization, all of these things have data to support their use, but they've never really been compared head-to-head. So it can get very confusing as a patient to try to figure out, well, which one should I do? Because there's not great data, if you go see 4 different physicians, you might get 6 different answers. And that's because we don't necessarily always know what the best option is because there's just limited data in rare tumors. So I think that was a really great overview. And we'll start with Dr. Hadfield. When you're seeing a patient with uveal melanoma, obviously there's the systemic therapies that we have of Kimtrac and the clinical trials that are going on with IDEA and Replimune and in Octura. But how do you approach a patient? When would you say, okay, I need to give this person systemic therapy, or when would you say liver-directed option may be best for this patient?
That was a wonderful overview of liver-directed therapies, and I think when you're meeting patients for the first time, there's a few things to kind of keep in mind. Liver-directed therapies are often technically challenging in different ways. So, for instance, sometimes patients just aren't good candidates for procedures, and they may be more amenable to systemic therapy.